morning on this great Tuesday morning. I'm Mabel, Jong. You're watching live coverage from the World Healthcare Congress here in Washington, D.C. This is WHCC TV, and thank you so much for joining us. And we're going to begin the day with a conversation with one of our favorite physicians that comes to the event. Dr. Robert Pearl is a surgeon, a former CEO, and now he is a podcast reporter and also a blogger, wants to change healthcare anywhere he can. Thank you, Dr. Pearl. It's so great to see you here today.
Good morning, Mabel. It's great to see you again.
Well, just want to get a quick check-in. You were a moderator of a panel, so tell us how that went and what you talked about.
So actually, I was a participant yesterday.
Okay.
And today I'm going to moderate an interview with the Data Commissioner for Health and Human Services. But yesterday I was on a panel about changing the game. How do we make the change to increase quality, greater affordability? And my view is you can't change the game until you understand the game.
Okay.
So I began by focusing on hospitals and drug companies, physician specialty groups. And if you step back, I teach at the Stanford Graduate School of Business, and if you step back and look at the game they're playing, it's how do I get market control to raise prices? And as strange as it sounds in a world of science, how do I hide the data? I'd rather compete on advertising. I'd rather compete on the amount of marble in my foyer or my reputation as a physician group than actually look at the outcome data. And if you take that now to the next level, what do we see? We see that hospitals are going to hide the costs, drug companies are going to hide the costs, doctors are not going to really be able to tell you what they're going to charge. You're not going to be sure whether in-network and out. All these pieces, I think, are really problematic today. And if we're going to change the game, someone, and I believe it will be the big businesses of this nation, could be the government, but is going to demand that transparency. You should know if you're going to have your hip replaced. You should know if you're going to have your heart artery bypassed. What's it going to cost me? I mean, every hospital is required to do this for Medicare. Why doesn't it do it for every patient? Because it doesn't want to. Okay. Similarly, I think when it comes to drugs, you should understand, how did they price? Why does this thing cost $400,000? How much R&D money was invested? But they don't want you to know that either. And similarly, when it comes to the medical groups, you should know how many cases per year does each physician do? What's their complication rate? At the hospital level, what's the complication rate? What's your medical errors? You can't find any of this. And it's not that it's not available. The game people are playing is that they don't want you to know, and we need to let every patient and every purchaser understand.
Okay, so what's going to get us to that point where these numbers are revealed? What's going to be the tipping point?
I think it's going to be the Amazon, Berkshire Hathaway, JP Morgan Chase agreement.
Okay, that's coming, that's here.
Yeah, that's here now. Understand, first of all, that all three CEOs are very smart people. These are not rash and radical people. They're solid business people who are going to take their time. But for the people viewing on TV and the people who are watching the interview, anyone who believes that this is about a not-for-profit venture to take care of the 1 million employees probably also believes that all Amazon does is sell books. No, this is Jeff Bezos wanting to take a $3.6 trillion industry. Today, Amazon controls about 17% of retail. He can do the calculation as a pretty good number if he controls 17% of a $3.6 trillion industry. No, that's where it's going. The CEO, Atul Gawande, is fabulous, and he's a very patient man. Everyone wants it to rush. It's going to be 4 or 5 years before you see it. But once it happens, it's going to happen fast. To me, I talk about it as being the force of disruption. Disruption takes a long time, and then when it happens fast. For the viewers who might have watched Game of Thrones, this is the White Walkers.
Okay.
It's years and years, and 8 seasons, and then finally you see the epic battle. I think we're going to see an epic battle, a disruptive battle when it comes to American healthcare.
What sort of conversations have you heard at this meeting this year that you're encouraged by?
I'm encouraged, first of all, by how people talk about value and prepayment and capitation. I haven't heard the word fee-for-service in any kind of positive context across all the days that are here. I'm encouraged also by the participants. I love this conference, this Congress, because it brings together business people, physicians, policy individuals at the highest level, and they're interacting and talking about those solutions, and that to me is extremely encouraging. And finally, I'm hearing people talk about called the cracks that are starting to happen. Mm-hmm. You're looking at primary care groups that are taking on complex patients in a fully capitated kind of way. You're looking at hospitals that are slowly moving in the right direction and making their care bundled in a positive type of way. We're seeing the cracks start to form, but as I said to you earlier, I don't think we're going to see it 6 months or 12 months from now. I'm pretty sure we're going to see it somewhere between 5 and 10 years from now.
Okay, that's still quite a ways from when we first started, right? I mean, we were talking about how much of our money is spent on healthcare. We're still talking about that. 8 years later, we're still talking about that. What are you up to in terms of, you've said to me, Dr. Pearl, that you want to change healthcare with your conversations and with your advice. What do you want to see in the immediate days ahead?
Sure. So I'm on my third career. As the first career, as I mentioned to you earlier at Mabel, as a surgeon, you take care of maybe 10,000 patients. I fix children with cleft lip and cleft palate. Exceedingly rewarding. I actually sometimes operate on more than one generation of individuals, the parent and the child. The families well, but it's only 10,000 people. As CEO, I had accountability around 12 million. It's a lot more people. I knew a moderate amount about their overall health. I didn't know them individually the way I had as a surgeon. And now my role is a keynote speaker. I give about 50 keynotes a year. I consult to about 12 different companies. I write my Forbes blog. I have my podcast. My website, robertpearlmd.com, has about 70,000 people coming to it every month. And what I'm trying to do in all that is to change American healthcare, consistent with the book that I wrote, Mistreated, Why We Think We're Getting Good Healthcare, Why We're Usually Wrong, the bestseller. And I talk about the 4 pillars. I want American healthcare to integrate. I want doctors to work together as one, whether in the same specialty or across specialties. I believe it needs to be capitated. As I said in my book, my father died of a medical error. Yes. I don't want others to die of a medical error. 200,000 people a year still die from medical errors, another 100,000 from lack of prevention, another 100,000, almost from complications, preventable ones, chronic disease. Almost 500,000 people die every year. And if we have capitation, we change the incentive where those things become even more important. The technology. I teach at the Stanford Graduate School of Business, and on the first class, I ask an easy question. What's the most common way that doctors send medical information back and forth today? That's the first class. So the students will say, we don't know. And I say, the fax machine. And you know what they say?
What's a fax machine?
Exactly. And we think of American healthcare as being so advanced. I just wrote a piece for Forbes about the electronic health record, how it slows physicians down, about the opportunities around artificial intelligence and virtual scribes to be able to potentially help that. I do a detailed analysis of that, the use of video, artificial intelligence for data, for diagnostics on visual samples. We have so many opportunities, and the 4th pillar is leadership. And we don't have the leadership in this country, particularly amongst physicians. Physicians spend all their time focusing on medicine, which is great, but now we need to develop those leaders to make the changes happen. I think that American healthcare can be the greatest. The podcast, Fixing Healthcare, that's always my concluding line. Let's make American healthcare the greatest in the world. Again, I think what the listeners and the viewers need to understand is it's not. We're the most expensive in the world, and we lag the other 11 industrialized nations. We're at the bottom of life expectancy, childhood mortality, all the things that we know. I think we can change. I think this is the time to change. And I go about speaking about it, coming to this conference, consulting to organizations, writing, because of my passion to make change happen, to save lives, and to make American healthcare wonderful.
Well, one of the topics that we are talking about thoroughly here at this particular meeting is medical tourism. Yes. The growing business of sending patients overseas to other countries for very complicated procedures. What do you make of that?
Oh, I've been a big proponent, particularly of Dr. Devi Shetty, the heart surgeon from India. He does heart surgery there for about $1,800 a case, and his results are better than 95% of US hospitals. I visited him about a year and a half ago. That day he did 37 heart surgeries, his teams, he has 6 teams, including a heart transplant, with remarkable outcomes. And a typical US hospital does 37 in a month, if they do that. In fact, most of them do less than that. And he's just opened a place in the Grand Cayman Islands, as you know.
Yes.
And he's building a 2,000-bed hospital on an island of 50,000 people. The people living there need about 30 of the beds. All the other ones, Miami's a 1-hour plane right away. I think it is coming. My best guess is that we're first going to change, we'll try to change internally, the big businesses, the Amazons of the world. But even they are going to be looking at this opportunity. Because why would you not want to travel to a place with great surgeons, by the way, better technology than we have in the United States, better outcomes than we have in the United States, with a 7-mile white sand beach, a tourist culture, remarkable food, totally safe, bring your family.
Yeah.
I think it's going to come. To the point you made earlier though, disruption always takes longer. You say, why couldn't it happen next year or the year after? Because we're not quite ready. But when it happens, we'll go from a relatively small slope to an exponential one.
But my point about medical tourism, is that more of a statement that we can't take care of our own right here in the United States? I mean, you end your podcast with, let's make American healthcare great again, because it certainly does not seem great right now. And people are leaving our shores to get help elsewhere.
It's not that we couldn't, it's that we're not willing to. You know, people talk about we don't have enough doctors. We have too many specialists. We have too many hospitals. What a person like WHCC has figured out is that when you have a lot of volume of a particular procedure done by a single individual or a single set of teams, the outcomes are significantly better and the costs go down. But accomplishing that, imagine how painful it would be to close hospitals. I was reading a statistic the other day that a lot of rural hospitals are averaging 2.5 patients a day in the hospital. What kind of quality could they be providing? You know,
if you only have 2 patients.
But it's the lifeblood of that community. We need a better solution. How do we convert that into a 24-hour high-end emergency type of service with rapid transition? How do we take expertise? There's a shortage of specialists in some of the rural areas. How do we use video to be able to bring that expertise into place? The electronic health record, how do we force the manufacturers to open up the APIs so patients, the application processing interfaces, so patients' data can be readily available everywhere? We know what to do. Drug costs, you know, we charge 2, 3, 4 times more for drugs in this country. Insulin, half of the people getting insulin, children getting insulin, don't get the full dose because their parents can't afford it. When I was in India visiting Dr. Shetty, I went to a biosimilar manufacturer. The insulin they sell is being done elsewhere. I toured the place. The product is fabulous. It's just as good as the United States. The cost, by the way, is 10%. 90% could be reduced. And our country won't let a biosimilar in. Why is that? Because the amount of lobbying and contributions to elected officials, the prolonged patent period, the legal challenge, these are the changes. And if we're not going to do it inside the United States, someone will do it outside. That's the history. Yellow Cab had the patent we call Uber and Lyft today. Kodak had the ability to make filmless cameras. Borders could have gone online. I want to say to your listeners again, the story of disruption. It takes a lot longer than you think. And when it happens so fast that you can't get your feet back under you and you go out of existence, out of business. This could happen to American healthcare, not next year or the year after, but somewhere in that 5 to 10 year range.
Okay, well you heard it here first. Thank you, Dr. Pearl.
Thank
We're
you,
gonna
Mabel.
check in with you again next year.
This is terrific. Thank you so much. I appreciate all you do, bringing the information forward to the American public.
Thank you, Dr. Pearl, and thank you for tuning in. We have many more interviews scheduled for you. Stay with us.